In the pediatric part of the exam, you're going to get a lot of questions about normal variants in babies and in older children, typically because it's a whole subset. In the rest of the exam, you're going to see that they're all adults. Whether they're male or female, young or old, they're all adults. In pediatrics, they're a lot younger, and so the physiology is a little bit different. And sometimes what might be abnormal in an older patient is actually normal in a child. It's very important when you're reading the test question to right away look for the age and the sex of the child or the patient. Even as adults, you need to know the age and the sex. More so in pediatrics, it really helps you with the differential diagnosis. When you might get some questions that are actually normal variants in children, so that's what we're going to be reviewing now, particularly in the newborn. This is what's described as cutis marmorata. Some people will sometimes call it modeling of the skin. It is a normal variant in a newborn, and when you see something like that, the first thing you think of is a temperature problem. When babies are first born, they don't regulate temperature very well, and so they can get this kind of appearance. Once they warm up, that appearance goes away, and as they get older, their vasomotor stability improves. You don't see that. It can be associated with some symptoms, syndromes, such as cutis marmorata telangiectasia congenita. Cutis marmorata telangiectasia congenita also goes along with some seizures and also goes along with other skeletal anomalies like malformed teeth. In this case, the cutis marmorata doesn't really go away. Cutis marmorata is also associated with Down syndrome, for example. This is what's known as a salmon patch. It is very common on the back of the neck. Some people will call it a stork bite. It is also common on the face, on the eyelids, and in the glabellar region. In that case, they call them angel kisses. And those are basically just little birthmarks of some blood vessels close to the surface of the skin. About 50% of babies are born with these, but 50% of adults do not have them, so consequently that means that they generally tend to go away. Don't really have any significance whatsoever. Sometimes when the baby cries, they will describe that the area gets a little bit redder. This, however, is a little bit different. It is a port wine stain. This does not go away. This is associated with Sturge-Weber syndrome that we'll discuss later. Port wine stains with Sturge-Weber syndrome are unilateral in the distribution of the trigeminal nerve. They will not go away, and Sturge-Weber is also associated with calcification, seizures, mental retardation. This is a strawberry hemangioma, also known as a capillary hemangioma. They may not be present right at birth. Sometimes it'll take a few weeks for it to appear. It starts out as a macule and grows and grows and grows over the first year or so, and then starts to resolve. Many times the mom will just bring it to your attention on a routine exam. The strawberry hemangioma can be anywhere on the body. It can also be somewhere else, such as GI malformations or in the airway. A typical presentation, at least for the exam, is a baby that comes in, a baby maybe 9 months of age, and over the last 3 months has had increasing progressive stridor, and now even at rest. The physical exam reports a strawberry hemangioma just like the one you see in that picture. You have to worry about some subglottic hemangioma. Strawberry hemangiomas can occur anywhere. They grow with time. The subglottic hemangioma, in this particular case, would be compressing the airway and causing problems. Typically, most hemangiomas like these do not cause problems. They tend to resorb with time. That's the same baby over a period of several years, and you see how it goes away. They typically do not require surgery. They may require steroids or laser therapy to make them go away, particularly if they are in a vital structure. For example, maybe over the eyelid or causing an airway problem. But typically they go away. It takes several years. This is a very important question or topic, which is common on the exam. So this is like a mega ultra high yield. This is a Mongolian spot. These are very common in all races. More common in dark-skinned races, but up to 5% of Caucasians will have Mongolian spots. Typically, they can occur anywhere, but most commonly they are in the lumbosacral area. Their major differential diagnosis is going to be child abuse. And the problem here, the differentiation here, is that the bruises of child abuse will go away and fade into the surrounding skin, whereas with Mongolian spots, they do not fade into the surrounding skin and have clear-cut margins. That's what you really need to remember for the exam. These are melanocytes that are kind of hypersensitive to circulating melanocyte-stimulating hormone, and so they get a little bit darker. And they tend to go away with time also. Remember that versus child abuse. This is erythema toxicum, another common rash in a newborn. It is not present in the first 24 hours of life. So read the test question, and if they're describing a baby that had a reddish rash with vesicles and pustules and the baby is 12 hours old, do not think of erythema toxicum, think of staphylococcal scalded skin. With erythema toxicum, it's basically the baby's immune system kind of just flexing its muscles. It will appear as an erythematous rash, which will develop pustules. The rash is migratory, so that you might see some lesions on the leg on one day, and then on the back the next day, and the day after that it may be on the chest, and then on the leg. So it kind of migrates around. It takes several weeks for it to go away. The baby otherwise looks fine and healthy. That's very important when you're reading the stem of the question, as opposed to staphylococcal scalded skin. If you scrape the lesions on erythema toxicum, those lesions will have eosinophils. But you really don't need to do any tests for this baby. It's basically a clinical diagnosis. This is also erythema toxicum seen on the feet. This is staphylococcal scalded skin. If you scrape these, you will see neutrophils. The other difference is this is a progressive disease, it's not migratory, and these babies look very, very ill. You see the rash on the right, on the left, I'm sorry. This baby looks like a burn. That whole area is denuded skin. Over here is what we call Nikolsky sign. It is not necessarily pathognomonic for the staphylococcal scalded skin, however it is very helpful. Nikolsky sign is when you scrape the skin in a linear fashion, the area will get very red and then blister up. This can also be seen in pemphigoid and bullous pemphigoid, so it's not pathognomonic but very helpful. This patient needs antibiotics. This patient, sometimes they can be in shock and need IV fluids and pressors. They're very, very sick. This is milia. There's two things that can plug up the skin pores. One is milia, the other one is sebaceous gland hyperplasia. These look almost like little whiteheads, very common in the nose. This is a lighter one, it's called milia crystallina. There's a redder one called milia rubra. Again, you leave the baby alone, reassure the parents. This is neonatal acne, not present in the first couple of days of life. It usually shows up at around a week or so, and it is, again, the baby's response to circulating hormones from the mom that were acquired through the placenta. This is just an exaggerated response, and it looks like acne, just like acne in an adolescent. These don't require any treatment and go away with time. It's a little more common in breastfed babies. It's not present during the entire breastfeeding process, however. They just go away on their own. This area here, this is a coloboma. It's this little defect right there in the iris. Okay? Colobomas can occur anywhere along the eye. It can occur as a coloboma of the lid or of the iris or even of the retina. And these are sometimes associated with syndromes, but many times are just isolated findings. Some people will call this the latch key defect of the eye from the old keyholes that used to be out there indoors. We don't have those anymore because everybody has slide cards, so you don't see them. This is what's known as aniridia. There is no real color to the eye because there's no iris. This is bilateral. You can see right there. Just looks like a big old black space, and that's because there's no iris there. It can be an isolated finding. For exam purposes, think of three things. If they mention aniridia, if they mention hemihypertrophy, right away you should start thinking of a Wilms tumor. We'll discuss them a little bit later. This is a cataract. When a baby is born, part of the newborn physical exam includes looking at the eyes with an ophthalmoscope. Not the easiest thing in the world to do, but you're going to basically be looking for a reflex, what we call the light reflex. The light reflex should be red or orangish tan in color. That means that light is bouncing off the retina and coming back, and that's how you're seeing it. However, you may have what's known as a white reflex, also known as leukocoria. If they describe a white reflex on the exam, right away start thinking of a retinoblastoma. In this particular case, we're not really seeing so much a reflex as we're seeing a haziness in the lens, and that is cataracts. Cataracts, right away, think of two things. Think of the congenital infections that we call the torch infections, and the other thing you should think of is galactosemia. Okay, so those are the two things that should come to your mind if they mention a congenital cataract in the newborn. This is what's known as a nevus of Jadison or a nevus sebaceus. Only on the scalp. Remember that. It's going to be present only on the scalp. It is a salmon-colored, fleshy-looking lesion. It looks like a wart that someone kind of squished down. There's no hair going through it. See that right there? There's no hair coming through it. Very important characteristic. These are basically followed by dermatologists, and typically around adolescence they're removed. You get better healing and surgical results, cosmetic results from them if you wait a little bit till they're older. They really don't have much consequence unless they do have about a 15% chance of turning malignant, and that's why you remove them around adolescence, and then the problem's taken care of. When we talk about the ears, we like to think of certain relationships. Gross malformations of the ears, think of associated renal problems. Now, these are minor malformations. Two of them are. The preauricular pit and the skin tag are minor malformations. The pit, which you see right over here, right in front of the ear, the preauricular pit, looks like a little hole. That pit, basically a normal variant, and is sometimes associated with hearing problems. Not every baby that has a pit will have a hearing problem. The preauricular skin tag is many times associated with a cleft palate. Not everybody that has one of those has an associated cleft palate, but just a higher risk, that's all. These are basically just cosmetic findings. This one, however, is known as microtia, and that's a really grossly malformed ear. First thing we need to do is make sure that there's an ear canal there. So a CT scan would be indicated. Everybody now gets universal hearing screening before they leave the nursery, so that's another thing that these babies need to have done to see if their hearing is intact. Okay, so now the microtia, baby may be normal. Also think of renal problems. The extreme example of a renal abnormality would be Potter syndrome, where they have gross abnormalities of the ear, and also they have renal agenesis or dysgenesis. As we go down through the physical exam, we'll go to the neck, and we have certain entities: the branchial cleft cyst, the thyroglossal duct cyst, and the congenital torticollis. What you see here on this slides here is a branchial cleft cyst. Externally, it looks like a lump or a mass arising lateral to the midline. Very important to remember that for the exam. It's lateral to the midline. These can get infected. Here on CT scan, you see a large branchial cleft cyst, and sometimes they can get infected, and that's what you see here. It needs to be removed. It's important to remember that it's lateral to the midline because you can get confused with a thyroglossal duct cyst. Those are going to be in the midline, and those move as the patient swallows. You can actually feel it going up and down. This is congenital torticollis. That's usually, they will describe a tumor or a mass on the neck, as is seen on the with the black arrow. It's a little knot, and it's a balled up, knotted up sternocleidomastoid muscle. The baby looks like its head is tilted to the side. If not taken care of, it can cause some visual problems. Typically, the only treatment the baby needs is just some passive range of motion by moving the head to the opposite side. Sometimes you can have the neck tilted to the side when the patient is born with a hemivertebra. That means that one of the vertebrae of the neck is not square-shaped or rectangular-shaped, and it causes basically scoliosis of the neck, and then you get a hemivertebra causing an appearance of torticollis. The chest, again, visually inspecting, look for breast hypertrophy. Babies are born sometimes with breast hypertrophy, male or female, just as a heightened receptor response to circulating hormones from the mom. Sometimes a little bit of colostrum or milk can come out of them, and the breast hypertrophy tends to go away with time. Supernumerary nipples. Remember that the mammary line extends anywhere from the axilla down to the inner thighs, and anywhere along that line you can have extra nipples. And lastly, you have pectus excavatum and carinatum. We'll show you pictures in a second. These are the supernumerary nipples that you can see. B are the normal ones. A and C are supernumerary ones, which are very small. Sometimes it looks like just like a little mole. On the other picture, that's what's known as Poland syndrome, and that is a congenital absence of the pectoralis major muscle, and you can see the asymmetry of the chest there. These are pectus excavatum and pectus carinatum. Pectus excavatum is also known as pigeon chest. Funnel chest, and pectus carinatum is known as the pigeon chest. Typically, they don't cause any problems. You can see, however, where pectus excavatum, on rare occasions, can actually compress heart and lungs and lead to cor pulmonale. But typically, it's just a cosmetic problem, and these are corrected around adolescence. They can, however, the pectus excavatum, when the baby is born and they're breathing, it can actually accentuate respiratory distress because the chest is already sunken in. In the abdomen, there's two major deformities that you need to remember. This one that we're showing you here is an omphalocele. An omphalocele has a sac-like covering. Remember from your embryology that the intestines exit the body in utero and do a 270-degree rotation and then come right back in, and everything is where it's supposed to be. With omphalocele, that doesn't happen. Remember, when they describe it, it's going to be a midline defect, as opposed to this one, which is known as gastroschisis, which is lateral to the midline. So the umbilicus is going to be there, and then you'll see something to the lateral to it. These have a high risk of malrotation and ischemic compromise, as you see with this one right here. There's a lot of, that gut is pretty dead or dead looking. These are going to be diagnosed in utero with ultrasound. That's the best test, is an in utero or fetal ultrasound to look for these, and then they were treated surgically as soon as the baby's delivered. The team is ready, and it'll be surgical consultation. They will then perform they build what's known as a silo, and every day they kind of push the little more bowel in. They unrotate any bowel that may be rotated. If it's ischemic, they need to take it out. But it'll be surgical consultation. Another common abdominal presentation is an abdominal mass. The most commonly palpated abdominal mass would be a polycystic kidney. Another mass that's palpated in the abdomen, but it's not really an abdominal mass, is an enlarged bladder. Most babies will void in the first 24 to 48 hours of life. If they don't, then you palpate a big mass right away, think of posterior urethral valves and an enlarged bladder. These are polycystic kidneys. They're enormous, full of cysts. There is a familial form, and you will palpate these as abdominal masses. You see the arrow on the CT scan. Other genitourinary problems. This is what's known as epispadias. This is where the opening of the urethral opening is located superiorly. And like I always say, when the baby voids, it gets itself in the eye. The hypospadias is on the other side, and when it voids, it gets its feet wet. And the hypospadias is going to be basically located in various parts. It'll be distally. It's known as distal, coronal, mid-shaft, proximal shaft. It really won't matter. All you need to know is that there is an abnormal opening. It is also a contraindication to circumcision. This particular hypospadias also has what's known as a ventral hood, and it also has chordee. Chordee is basically a kink, downward displacement kink of the glands in relation to the shaft of the penis. This is an undescended testicle. Testicles can be retractile, undescended, or absent, and they can be descended, which would be normal. In this particular case, you can palpate the testicle in the inguinal canal. If you notice down here in the scrotum, it looks kind of empty. This is an undescended testicle. A retractile testicle would be one that you could bring down into the scrotum, or if the patient is placed in warm water, it automatically goes down. A retractile testicle is due to a hyperactive cremasteric reflex, which brings it up quite easily, and they tend to get better with time. An undescended testicle is palpated in the inguinal canal, cannot be brought down into the scrotum, and if it does not come down on its own by 1 year of age, it's recommended that the surgeons take care of it. There's a higher risk of carcinoma of the testes if you don't take care of these undescended testicles. Here we have a combination slide again. We have bilateral inguinal hernias, so it looks like swelling of the scrotum. You can look for the word transillumination. On physical exam, they will transilluminate. You put a light, shine a light, and it gets like a nice dark red, and it transilluminates. This baby also has bilateral inguinal hernias. You can see the swelling of the inguinal canal. You can palpate them sometimes. So that's hernias right there, and on this side also. And this baby also has what's known as diastasis rectus muscles, which is in the center where the abdominal muscles don't come together completely in the middle. And sometimes you can just palpate a ridge or see this ridge right up and down. Okay. In most babies, that takes time. That goes away with time. In older adults, when that appears, that's really not going to get better on its own. Some babies will have umbilical hernias, and these basically will get better on their own. A lot of times grandmothers like to put a quarter on them and tape them down, and after about 5 years, they've gone away. Well, if you don't put the quarter and tape them down, in about 5 years, they've gone away. So umbilical hernias pretty much reduce on their own and don't mean a thing. Umbilical hernias are also associated with hypothyroidism. That's part of a complex of other things that you'll see with hypothyroidism, and we'll discuss that a little bit later. We talked about ears and genitourinary. Now we're going to talk about another association, and we're going to talk about the extremities. Gross abnormalities of the extremities always think of associated cardiac problems. These are not as bad, but we'll show you a couple more in a second. This one here, down here, is called syndactyly. And the fingers tend to be fused together. In the test, they always like to ask what's next, what's best. Well, the next test for this child would be to go ahead and get an x-ray of the hands to make sure that you have one set of bones or two sets of bones. If there's two sets of bones, that means that you have two fingers, and a surgeon can take care of this cosmetically. The other abnormality here is polydactyly. Polydactyly means you have more than the allotted number of fingers. So here we see 1, 2, 3, 4, 5, 6. That's a fully grown finger, though, and so that surgery would not be advisable. That finger has a bone and a full supply, so that you probably just need to leave that alone. And the last one that I want to show you is the one on top, which is what's known as a finger tag, and that has a very thin stalk. It does have some circulation, but there's no real bone there, and the treatment in that case would just be to simply tie it off at the base, and it'll auto-amputate. These are more severe abnormalities of the extremities. These are the ones that are really associated with cardiac problems. What you see here is an absent radius. Okay. Sometimes we have what's known as TAR, thrombocytopenia absent radius. We also have what's known as Holt-Oram syndrome, and this is Holt-Oram syndrome over here on the right. You have a patient has the right number of fingers, but if you look at the thumbs actually have three bones in them, just like another finger. So the thumb has like a third bone in there, and it acts like another finger. And we'll see that with associated cardiac abnormalities. We'll discuss that in the cardiac chapter. So remember to try to maintain a correlation between an association of severe abnormalities of the extremities, particularly the upper extremities, and cardiac problems.